this threshold is not a deterministic variable, it's a stochastic variable. And if you don't deal with as a stochastic variable, then what you may come up with is something which might not reflect the real situation. And also second thing is that it is also not a time invariant variable. It may increase, it may decrease based on the dynamics of the health system. The last part is basically the applicability part in the Indian context, the practical issues related to the applicability. It is, of course, as you say, that is very relevant. So it is very important to explore different ways of estimation in Indian context. Several issues may be considered in this case, and I'll try to give some suggestions here. When you look at the Indian healthcare market, it's highly complex and pluralistic. The degree of complexity increases as you go down in the ladder of healthcare system, that is primary healthcare. Interestingly, the role of public finance also increases as you go down to the primary level. In other words, the relevance of public health expenditure and role of public expenditure is more in the case of the bottom of the pyramid, which is more complex. Now, how complex it is? The health market is basically, when you look at the health outcome, it is extremely difficult to link the resources and outcome. There is a complete zigzag, complete hodgepodge between these two extremes. On the one hand, there are health departments, but there are other departments, nutrition, for example, sanitation, for example. They're also contributing to that. But in addition to that, there is a whole range of informal or formal private sector providers are there which are contributing to the process. How to join the dots? It's difficult, but it needs to be done. So a templated version of switching from resource to outcome may be extremely difficult in the Indian context. We need to do parallel studies on the stories behind it, stories underlying the conversion of resource into outcome. Second thing is that, if you do the exercise in the whole country basis, the aggregated data, I think it is less meaningful. Coming up with the same elasticity assumption, same threshold assumption, the whole country is, I think, will not be very much meaningful to the policymakers. What can be done probably is that whether we can group the states and have different thresholds for each group of states. For example, EAG states itself should have different thresholds than the southern states, or northeastern states should have different thresholds, and which obviously takes care of the efficiency and equity concepts also. Alternatively, one can use weights, some kind of weighted thresholds, which in the extremely ideal case would be a continuous variable. So each state will have one kind of threshold weight, which is weighted according to the efficiency and equity. Also, it should not be made the whole healthcare expenditure. If we can group the according to the disease or health outcome specific groups. For example, if we focus initially on a very, say, under 5 mortality, or if we focus more on a particular procedure in the tertiary level and do some pilot testing, probably that will be much better than grouping all health expenditure in one bracket. And of course, the interesting case in Indian scenario will be, how do you handle the health specific expenditures that is coming from the health department, but what about the health sensitive expenditure, for example, which are done by Department of Education, Department of ICT in Women and Child Development, and of course sanitation and other things. So should we include that? Should we include out-of-pocket expenditures? There are pros and cons on both sides. We're not going to discuss these things. And also, how to get quality costing data that already mentioned in the Indian context. The data probably we will be using now is actual expenditure data across the states coming from some sources, but these are exposed data. But how to know that what exactly the resource use, what is the optimum use of resources in a particular health facility or in a particular category of health facilities. And finally, I agree with Indrani that in the context of India, health technology assessment probably more meaningful will be probably health program assessment, where we look at not only the technological point of view, but also the governance, but also the accessibility, etc. All these issues. So with that, I close. Thank you.
Thank you, Dr. Kanjilan. Would you like to respond, or maybe would you like to have a few more questions before you respond to that? You'd like to respond? I'd request Dr. Claxton to respond, please.
Thank you very much for those both really thoughtful, discussing comments. I really appreciate the time that's been taken. I also really appreciate the idea that the concept, at least, of a supply-side notion of health opportunity cost is something relevant for decisions. Since we've come to India for the first time and our experience in Chandigarh, we've started to get some appreciation of the complexity of the system and the fact that it is so much more complex than the UK. So those points are well taken. I was asked something about the experience in the UK, and I guess this is relevant. I think this is relevant. My experience and my greatest frustration is the fact that we didn't clearly establish that the notion of a cost effectiveness threshold was an empirical scientific question. It was not something that people could dial up and down depending on what the political pressures might have been. And that is my biggest frustration, that we didn't establish that. We didn't establish that at the very outset. The reason why we weren't able to establish that at the very outset was that we didn't have any empirical estimates at the very outset. And it was only somewhat later that we were able to challenge what had been done with evidence. And by that time, politically, NICE had already committed itself to saying yes at 30, 40,000 and did not feel able to change and reduce its threshold to a point which would have made things affordable for the NHS. So our original work funded by the Medical Research Council was work that initially NICE had asked the Medical Research Council to fund. By the time we reported that research and they realized what the results looked like, they were not interested and are still uninterested. NICE as a body is uninterested. It doesn't want to know because it challenges the way in which it does things and it challenges the relationship that it has with stakeholders. That's very different within the Department of Health. The Department of Health is very interested and uses these estimates internally within the Department of Health. But even the Department of Health is unable to force NICE to change the way in which it makes decisions because of the lobby, because of the political pressure to say yes to new drugs. So one lesson for me and one frustration would be establish the fact that this is an empirical scientific question. It is not something to be dialed up and down by people depending on the way in which the wind's blowing. I'll try and be brief on the other things and then open for discussion. I think a few things were said about, I think there's a general theme, which is we're estimating this on average across a healthcare system that might be very different. In the UK, it's relatively homogeneous. That's absolutely true. We're estimating on average what is the health effects of a change in spend on outcome. Within that average, there is indeed heterogeneity. And there are parts of the NHS that's more efficient than others. And certainly one of the things we propose to the Department of Health is that we do our best to try and explore that as a means of identifying those areas, local areas, where improvements in efficiency you might expect to be more possible, and use this to provide benchmarks that are specific to local areas and different providers. But I absolutely take that point. I think there was another theme, which is that we are simply looking at the relationship between spend and outcomes. The process by which expenditure changes outcomes is really complex, and we don't unpick and figure out exactly how it was that this expenditure changed outcomes. What different things were done in different areas. We have tried to look at that in the UK, try to find out how people responded to cost pressures. Has to be said, in the UK that's been extremely difficult, and we haven't really been able to find anything useful there. So we are kind of stuck with this kind of black box, you know, what was the change in spend and what was the change in outcome? And I entirely agree that actually understanding that process is really valuable, because there are efficiencies that we can gain. Just maybe a couple of other things. One thing that we do gain by looking at the relationship between spend and outcome and how that changes over time is we can start to see how our healthcare system kind of responds to increasing financial pressures. During that period of time of 10 waves of data, the NHS came under increasing financial pressure, and we can see evidence that the NHS responded by technical efficiency gains, by getting more health per pound in particular disease areas on average across the NHS. But we also see that it improved efficiency through allocative efficiency, by allocating resources to programs which were more productive of health. So we can see both those effects happening within our healthcare system over time as it comes under more financial pressure. And I guess the overall theme from that picture of 10 waves of data is that the increases in productivity have outstripped the increases in real expenditure. So what else? And finally, is our healthcare system about maximising QALYs? No, I agree. Should any healthcare system be simply about maximising QALYs? No, I don't think it should. I mean, I think there's two responses to that. The first one is, insofar as there are other things that we care about that we can quantify, then sections of the population that are seriously disadvantaged. But at least that trade-off's on the table and he's been made in an explicit and accountable way. So I'm going to stop there, but thank you all very much for that.
I have, I think, somehow the focus, we know that the HTA also has to be placed in a clinical guideline kind of an environment, and not just the cost, because you also have nice guidelines which actually influence the entire effectiveness. And that's something we know that in India, roughly around just 6 or 7 conditions have a national clinical guideline. So it's not just about sharing what is the cost effectiveness of drug-eluting stents versus bare metal, but rather the entire care pathway of how you will conduct the entire procedure, right? So I think for someone who's working on guidelines, I think it's important that just the intervention-based cost effectiveness to show that one is cost effective or the other, and not looking at the overall care pathway would be a huge, I would say, a negative way of looking the value of cost effective. That's number one. Number two, I think we know that the GDP kind of logic is little difficult in a developing country because states will have its own GDP. So can you use a national GDP to compare Uttar Pradesh and Maharashtra, which are having its own GDP? The second complexity is, do you look at thresholds based on equity? Because we know that the difference of the paying capacity, if you look at a higher income to a lowest income, is it's a wider large. So do you look at equity based threshold, or what Barun was saying about, do you look at a geography based threshold, like an EAG state having its own? I think the complexity of threshold does not consider these when we're looking at a context of India. And third, I think, I'm not familiar with the NBF framework, but one of our examples that we've just finished the cost effectiveness of screening for glaucoma, we could consider it's cost effective. But the moment we put it into a budget impact model, we are not finding it to be, it's actually quite high, because in terms of just diagnosing and investing on doctors to diagnose glaucoma, because there's only 12,000 glaucoma specialists, even to treat MBBS or an optometrist, the capacity to even identify glaucoma suspect, not even diagnose, is such a huge investment that we found glaucoma screening to be effective, but the budget impact is such a huge component. So I think somewhere considering, as I think groups like Murli and other people are saying, that how do you consider the investment on other aspects beyond what? And lastly, from an evidence perspective, for example, do you consider it's not always economical to conduct a cost effectiveness in Indian setting, because the way of, so traditionally from an evidence perspective, I might consider doing a systematic review of cost effectiveness. So how do you drag those evidence to India without actually conducting a primary cost effectiveness? Do you use that, maybe using some transferability checklist? Is there some appropriate way in which you can consider that? Or do you always say, no, just the way that the HTA framework works in the UK, we should consider a primary cost effective study in India as well to justify that? And I think the last one is about the entire challenge of opportunity cost. So for example, one of our studies that we are doing is on cost of dengue in just one city called Surat in Gujarat. And just on the diet component, we found 3 variations. That the hospital will, for what category of patient gives diet directly. There's another set of patient where the diet was paid by the patient. There's a third set where they're taking it from the local canteen. So I think the variation of opportunity cost, even in one single city for us, was quite large. And I think that complexity of indirect cost or opportunity cost have to be understood, because I think Barun mentioned about the direct cost component, but I would be also considering a lot of differences in indirect cost. How would you consider that? So these are things that I would.
Let me. This section was not supposed to be on India. And since I'm the discussant for the India section, all my comments are taken. So let me ask you something else. So if you have thresholds that kind of evolve as discussion, that the evidence comes in to you, what is the deal from the firm side? Because I could be a particular technology producer and making it even more effective, and suddenly find that because I'm doing worse relative to some other sector, because at the NICE you're comparing across technologies or across disease types, right? For firms that need to make long-term investment, that's a bummer, right? Because they could be making something slightly better, but on the other hand, there's another disease type that makes something even better, and suddenly you lose, you're not part of the set that's chosen. So that there must be a kind of, I mean, I'm not a drug company guy. I mean, I know that they earn a lot of money, but it's kind of little problematic from firm investment side, right?
Okay, so what we've estimated is how much we can afford to pay for a QALY in the NHS. No matter which disease area you generate the QALY, we'll pay £13,000. If you create a product that will generate a QALY in whichever disease area, we pay £13,000. So, in a way, it's sending a very...
Not something for all. For example, let's say you make something for 20, but yeah.
Okay, so insofar as our healthcare system over time gets more productive because we have better technologies or better medicine, then of course that cost effectiveness threshold will start to decline. It will be offset insofar as we decide to spend more on healthcare, and how that kind of balances out, whether we see a constant threshold, a growth in the threshold, or a decline, just kind of depends on the interplay of those things. I guess what I'd say is that patented medicines need to compete with the technologies we have available and how good we are at medicine. They need to compete against everything else we could do in our healthcare system. If our healthcare system gets better, they're going to have to compete better. I suppose what I would say for industry is at least this is a clear, predictable signal of how much we can afford to pay. You then need to decide what to invest in. If we can only afford to spend £13,000 on one QALY, then maybe some of your investments are not worthwhile and are socially inefficient, and maybe you shouldn't make those investments, and maybe we could use that capital to better use in other ways. So it's not good news for the pharmaceutical sector, because in the UK it suggests that the prices charged are probably 3 times too high. And it's not good news for the pharmaceutical sector because what we've seen suggests that our healthcare system becomes increasingly productive over time. So we're not expecting that threshold to increase. The Department of Health in the UK has adopted a view that £15,000 is appropriate, and that won't change for the next 10 years because of the kind of financial pressure that the NHS is under. So I don't know if that answers it.
Well, as a professed skeptic of the use of QALYs and DALYs kind of analyses, let me say I found this a very exciting presentation because it provided evidence for opportunity costs. That's something that from a health systems perspective, we argue and analyze with the kind of programs and technologies that do get taken on in the public system. And often that goes unheard because there isn't evidence of the kind that the policymaker can see. So I find this extremely relevant. The only problem, as everybody's voiced here, is the complexity of our system. And therefore, how do we use this at all? And thinking of that, the only way that I can see at this point, bringing this very valuable input into our analysis would probably be if it's not a national level analysis that you do or a calculation or an estimate, but decentralized small level use of this methodology to illustrate that in these kind of contexts, this is what the opportunity costs are, and therefore this is what the estimation and the health benefit actually is, or the negative balance that it may come up to. And that in our kind of policymaking exercise, and I'm sure Shiva Prasad will be able to make us understand that better, with the lack of national evidence, because of all the complexities that are there, policymaking often comes on the perceptions of benefits and the negatives of the inputs that come. So if you can illustrate that even through small studies, that may go a longer way than trying to build national estimates which actually don't come close to reality at all. and are just too much approximations to actually make impact. So that's sort of, I'm just trying to make use of this very certainly, and would be look forward to your writing on this. Thank you.
I had sort of one question, something just conceptual in my own head. So basically, unless you have a universe of interventions that is being delivered to full need, right? So everyone's need is met, or you have, you know, all known interventions are being assessed at the same time. I mean, using one criteria for threshold, you'll never get, there'll always be interventions that will turn out to be more cost effective in a delivery sense. As such, don't you just need additional criteria to be able to resolve your decision-making problem that is beyond the cost effectiveness threshold?
Okay, I'm not entirely sure I understand, but let me say what I think, and you correct me. So we have an intervention, and it's fairly cheap and easy to deliver to a certain segment of the population. For another segment of the population, it becomes increasingly more difficult and costly. So at a given threshold, it's cost effective for the first 50% of implementation, but it's not worthwhile for the final 50%. Is that?
There you have like let's say you have 100 interventions, right, that you can choose between. If you know the cost effectiveness of all those interventions before you design your benefit package, you can take the ones that are most cost effective. However, in the real universe, you know, you have lots of constant interventions whose cost effectiveness you don't know at this point, who will come in the future, and many that are not delivered to full need. So when you're choosing between these, then you would need additional criteria than cost effectiveness to be able to make your decisions, irrespective of how good you're coming at a threshold. So I mean, coming up with a threshold using opportunity costing improves the quality of that metric, right? Or the level you're coming up with, because you're using more information. But your decision making will still need other criteria.
Okay. I think we could think about the threshold in one or two ways. That we don't know all the things that we currently deliver within our healthcare system, and we don't know what the costs and effects of everything are. So we can't do the bookshelf that was shown earlier on. We just don't have all the information for that bookshelf. But what we do know, or what we can estimate, is the effect of a change in spend on outcome, which is what we've done in the UK. So we don't know what the bookshelf looks like in the UK, but we do know, if you like, the cost effectiveness of the last book that we put on that shelf. We've estimated that. And we can use that to figure out, for any new book that comes along, should we put it in? Or for any book that's already in there that we look at, should we throw it out? So that's one approach. The other approach, I think, as you're saying, is that we try to get information on all the things that we could do and figure out how we put them in, but reflecting the fact that we won't be able to implement them at full levels because of other constraints. Yeah. We can then ask the question, should we be devoting our resources to relaxing those constraints to ensure that this limited number of things on the bookshelf get fully implemented, or should we be spending those additional resources on just putting more books on the bookshelf, even though we know they're not going to be fully implemented? Is that maybe not? Maybe I didn't quite understand.
Just some random thoughts. I think this is very interesting, but I kind of agree with Borun and Ritu that the health opportunity cost would be very context specific. So, I mean, I'm thinking of India. I'm really, honestly, this is how we have to learn from you. But the fact is that in Tamil Nadu versus in Uttar Pradesh, what you can do with that extra money would be very different, first. Secondly, who's investing? Is it the central government, is this the state government, or somebody else are coming and you know, investing hugely on a particular state? And I'm wondering whether we can use the same yardstick to judge health opportunity costs depending on who the funding agency is. So that's my second question. Maybe the answer is simple, but it doesn't seem so to me. And thirdly, again, coming back to something everybody is raising. can we actually do what you have done in India? Can we actually replicate this model? We don't really have anything close to the NHS that you have. So when you don't have a model where your government is, the NHS is actually funding everything, is it really something that we can use reasonably? And the last is the date. Suppose even if we assume that we can use this model that you have in our context, the data demands are huge. And we just don't keep data the way you keep data in your country. So we can't even get started. And the final point is, suppose we do have this NHPS launched. I mean, we already have a scheme which is National Health Insurance, the RSPY, but suppose the National Health Protection Scheme does come in, then I can see some use of doing this kind of analysis to incorporate additional interventions within a particular essential health package. So whether hemo or some other kind of dialysis should be part of our UHC package, etc. So it does have its uses in a very well-defined, limited setting, is what, and that's applicable for most countries, I would think. But I just thought that I'll just raise those issues.
I mean, just to supplement what Indrani said, as I understand, the NHS is a very GP-driven system, and it's a demand-driven system. Whereas in the Indian settings, it's a supply-driven this thing, because it's programmatic. We have these objectives. The program demands that iodine deficiency should be eliminated, leprosy eradication. So it's very programmatic. So in such a setting, when you have a technology assessment, how valid would it be? Because irrespective of what the HTA says, the interventions go in these particular areas. So to that extent, and as Indrani said, data demands are very high. India does not have a robust data, time series data at the moment to make evidence-based research possible. So in this kind of a setting, can we replicate your model here? Thank you.
So I entirely agree that the perspective on opportunity cost depends on the level of the decision maker. So it strikes me that if there is a federal decision to be made that is going to impact across all states, that federal decision maker needs to know, in principle, what the likely health opportunity costs are going to be in all the areas where that single federal decision is going to impact. So they need to have some understanding of health opportunity costs and how they are likely to differ across all those states. For a state level decision maker, they need to know health opportunity costs for their perspective in their state. But again, as has been said, and those are likely to differ by state. It also depends on where those health opportunity costs fall. If this is something that is specifically about the public sector, then the question is, well, what are the health opportunity costs of public health expenditure at state level? If it's a policy that's going to affect the private hospitals, then it's a question of trying to think about what the health effects of private healthcare expenditure are, or even out-of-pocket expenditure. So I'm not suggesting this is easy to estimate. I'm just saying, in terms of what you would want to know, in principle, it would be the health effects at different levels and for different categories of expenditure. Is that easy to estimate? No. I think, what can we do? Well, we could think about those more kind of vignettes of looking at specific instances to try and get some idea of what is likely to happen across a particular category and level of expenditure based on some quite detailed work in a particular unit, a particular level. I don't know the Indian data, but can we replicate the UK work that is at a disease level? I doubt it. I think the level of data is probably too much. Whether there's a possibility of thinking about an all-cause model, trying to estimate all cause effects based on cross-section and time series, Whether that's possible, I think, remains an open question. There's been more recent work that's shown that it's possible to estimate all-cause models of changes in expenditure. So whether it's possible to estimate an all-cause model mortality for particular states or particular categories of expenditure, I mean, ideally that would be kind of what you'd want. Whether the data will allow that, I think, is another question. On the programmatic issue, I mean, again, I suppose if funding is vertical and decisions have been made to vertically allocate that funding into programs, then it's kind of useful to think about what evidence can we gather to figure out what the health opportunity costs for each of those programs are, because then it starts to tell us something about potential reallocations between programs. So any differences between programs would suggest that a reallocation would improve health, or the fact that programs differ might reflect the fact that we have social values that means that this program might have a very high cost per quality, but there's a good reason, because our social values mean that we regard these health effects as really valuable. That's something that our work has been used for in the UK, so I didn't show it, but we can look at the cost per quality, the implied cost per quality by those different disease areas, cancer, circulatory, and ask the question, does this really reflect differences in efficiency? Should we reallocate between these areas? Or maybe there's a good reason. You know, our cost per quality for maternity and neonates in the UK is very high, the highest cost per quality based on our estimates. That probably reflects the fact that of social values, that we really want to avoid mortality in those areas. So I don't mean to keep bringing it back to UK, because I agree that the key question is it relevant here, and what could be done here given the data availability? So I agree, we've discovered that the Indian healthcare system is a lot more complicated. We have got different levels from federal to state, and we've got different categories of expenditure at state level between public, private, out-of-pocket. And ideally, we would want to try and estimate the effects of each of those categories by level.
I just want to echo the remarks of Dr. Sheila Prasad. We used to work in the Ministry of Health. It's a very, very interesting and very important concepts you have thrown light here, but not only the complexity of the country is so large, and we have a very, very rudimentary system of health financing happening, health financing, knowledge, and translating that into programs happening in this country. So Dr. Sheila Prasad was there as economic advisor. You know, ma'am, the NHM is a typical case in point, where the way we allot the formula for allocation of funds to the states is what we set up in 2005, and by and large based on population. We recently had this new health index for states, and with about 24, 25 now, allocation of funds, ranking of states going to happen on that. I don't see a single indicator on health financing except for maybe out-of-pocket expenditure for a delivery in a public health sector. So this is a state of affairs, and the concepts of qualis, loss, qualis gains, it's so attractive, but then apart from the complexity, the capacity in this country is quite low. So I don't know, this is from my experience working in the government. So how we can translate these into some sort of, action and some sort of, better health programs, I really don't know.
Yeah.
So, Carl, I just want to ask you something slightly different. So, forget the NHS system for a second. So, I mean, I know playing like a Brad record, this NHPS. So suppose we were to evaluate 3 options for moving towards universal health coverage, right? So we look at social health insurance, we look at insurance, private insurance driven thing, and we look at public tax paid system like you have. Now, your concepts of health opportunity cost can actually also be applied at these systems level, right? The programmatic level. Has it been actually done anywhere where you actually look at, I mean, you know, what we should be doing in India today and quickly producing some evidence that maybe we have a bad choice of moving towards UHC is if we can put our heads together and apply your concepts to looking at 3 or 4 options of moving towards universal health coverage. Those are huge, humongous tasks, because to assess the effects of SHI or insurance on the population at large may be very challenging. But I was wondering whether we can do it for state, you know, just as a pilot, and do it for demonstrate that it doesn't, insurance doesn't work, private insurance doesn't work for UHC. So I thought.
Absolutely, absolutely. So I mean, maybe James might be able to talk about the work that might start to be done in the United States. So even in the United States, and I'm very keen that this work be done in the United States, there is a relationship between healthcare expenditure and health outcome on private insurance plans, and the additional costs imposed on health insurance plans and health outcomes. You know, it's not just about a public system that's collectively funded. A private system that incorporates high-cost medicines that aren't very effective, it increases premiums, it displaces other people from insurance. It means that when people need to claim insurance, they can't pay the co-pays. That all has a direct health opportunity cost. So I totally agree with you. And one of the things I'm most keen to do is to think about ways in which we can use the idea of looking at differences between marginal productivity between those different kinds of financing and deliveries. So insofar as we were able to do this, I imagine we would find that the cost per QALY for public health expenditure was very low. I would expect the cost per QALY for private health expenditure to be very high, and out-of-pocket expenditure, I'm not sure which way that one will go. There's only one paper that has attempted to break that down into those 3 categories: public, privately pooled, private insurance, and out-of-pocket. And that was a paper by Rodrigo and Pete Smith, which is in the Journal of the Royal Statistical Society. That was maybe 3 years ago. So, and they were using aggregate country level data. I think there are some problems with the estimation, if I'm to be entirely honest. But I think the fact that they tried to do that is important. Insofar as it was possible to acquire spend and outcome at a lower level, at state level, then the possibilities of being able to estimate something is kind of better. But I agree. I think that would be a really good way to go, to compare those different systems.
Yeah. Okay. Carl, this is, I mean, what you showed us is very impressive. In a sense that, and this is true for not only in the health sector, but in practically every public service provision sector, is that the use of evidence for informed public policy and policy making is becoming more and more mainstream. Now, of course, leaving aside the Chinese whisper element of it, that that other people are doing it, so I must do it, that kind of thing. It's unambiguously good in a way, but the problem is the internal mechanisms of why something is working or not something. Would you advise a country like India to actually replicate this, or do you think that there are other fields which are emerging which would actually help us in a more efficiently and cost efficiently generate the evidence for, you understand what I'm saying, right? So is this the path that we should take, or there are more cost effective and effective, simpler ways of actually generating this evidence?
Yeah, let's be clear, in the UK, we don't evaluate everything, far from it. We actually evaluate a very small part. And the key question is, how do we direct that effort and those resources? Now, one of my other frustrations has been the way in which that has been directed. So that has been primarily directed at evaluating new branded drugs for political reasons. Borrow strength from that evidence that's available elsewhere. It seems incredibly costly to try and repeat that. Think carefully about which evidence it might be more or less generalizable. Be explicit about whether you think there's any potential for bias or additional uncertainty insofar as you're borrowing evidence from other studies conducted elsewhere. I suppose the thing that's probably difficult to find elsewhere is estimates of resource use and then costs, attaching Indian prices to resource use. Insofar as you've got evidence about resource use that you believe to be similar, then I would start by using that rather than the primary data collection, which is very expensive, and then attach Indian prices. But I think if there's anything that's difficult to use from elsewhere, it is that resource use and price in the Indian context. Now, as I understand it, there's bit by bit going to be a database created of those costs, which can be reused. So you invest in primary data collection for costs around certain procedures, and then that's put in the database and other people can use that. So for example, in the UK, we very rarely get involved in primary costing because we already have, reference costs available to us. So it makes it very quick and easy for us compared to the current situation. But it seems to me that bit by bit, as different evaluations are completed, starting to complete that database of unit costs would be useful. So I'm not sure if it's just my take on, I guess, the way I would go. But I would also target the topic selection. So one is to make the evaluation as efficient as possible. by using as much data from other sources as you can, by reusing unit cost data where that's been collected. But then the other way of making it more efficient is to make sure you only do it where it really matters. And I think there's two things that are not been done and fully implemented, where you've got a strong prior belief that this is a really good buy for the Indian healthcare system. And the other one to target are those things that you know have been widely done, but you've got a good prior belief that this is not an effective use of a resource. And I would target those two, rather than constantly looking at the next new technology that's coming through, because that's not where the real value lies.
Well, I think we've come to the end of the session, and I'd just like to say that the new health policy 2017 does focus on the need for health technology assessment, and learnings from the global arena and evidence from there would help us in developing our methodology, which is country specific and specific, state specific, would help us in coming to a kind of an understanding as to what is the pathway that would be best suited for India, whether we go in for an assurance-based model or an insurance-based approach, especially in the tertiary sector. And this has been a very interesting session. I would thank, Professor Claxton and Professor Muralidharan, Professor Kanjilal for making it so interesting. I thank everybody here for their interaction and for all the suggestions and for all the